The subcommittee hearing is called to order. Good morning and welcome to our witnesses on the first panel. This is the second in our series of hearings on health reform. Today the subcommittee will examine issues surrounding the affordability of health coverage. Now more than ever, securing quality health care coverage at an affordable price is not possible for millions of American families. First and foremost, health insurance has become too expensive. As health insurance premiums continue to outpace wages every year, people can no longer expect to pay a reasonable price for health coverage. And as we talk about health care reform, we have to ask ourselves, what should we expect to pay for health care coverage, and what should that coverage include? Cheap plans that offer little protection, such as high deductible plans, are not a solution, in my opinion. We need real reform that makes quality health care coverage affordable to every American. And in order to do that, we need to change the rules which govern the way people obtain health care coverage, particularly within the individual market. I'm particularly interested to hear from our witnesses today about new ideas like a health exchange or connector, similar to the one in Massachusetts, a public plan option, and an individual mandate that can help provide individuals access to affordable options for meaningful coverage. I also think it's important that as we talk about making coverage on the individual market more affordable, we don't do anything to disrupt the affordability of coverage in other sectors. There was talk last week and in the media about eliminating or cutting back on the tax exclusion for health benefits offered by employers. This was an idea promoted by former President George Bush and was a key component of Senator McCain's health care proposal during his presidential campaign. But obviously this is controversial as well. The employer market is already declining. It's becoming increasingly difficult for both employers and employees to afford health care coverage, and eliminating those tax incentives may further exacerbate the affordability problems we already face with employer-sponsored insurance and make it and not necessarily do anything to improve the affordability of coverage in the individual market. Again, these are all issues that I think we need to discuss, looking at places like Massachusetts, public plan options, individual mandates, and the tax exclusion for health benefits. Not that I'm taking a position on any of those right now, but I think these are important things that we have to look at. I want to thank our witnesses again for being here today. I know we have a very distinguished panel, and I'll now call on Mr. Deal for opening statements, and then we'll have opening statements from other members, both Democrat and Republican. Thank you.
Thank you, Mr. Chairman. Thank you for holding the hearing today, and thanks to the witnesses for being here, and I believe we have two panels of them, so we're going to be here a while, I suppose. Obviously, as we broach this subject of how to reform the health delivery system in this country, it is a difficult task and one that has many facets to it. Dr. Reinhart, I was interested in reading your article that appeared back in January on in the New York Times on the question of pricing. As you probably know, this is an issue that has been one that's been important to me in the area of transparency of pricing. It's probably one of the most difficult issues to understand and try to get a handle on. We have so much differences in pricing of health care services in this country that it is, in fact, I think one of those issues we have to begin to wrestle with if we're going to decide how we're going to approach the delivery of health care, because pricing obviously has a lot to do with it. I'll look forward to the testimony of the witnesses. There are a lot of issues that we have not talked about in previous hearings, and I'm sure that these two panels today will broach some of those subjects that we have yet to explore. And thank you for being here, and I look forward to your testimony. I yield back.
Thank you, Mr. Deal. The gentlewoman from California, Ms. Eshoo.
Thank you, Mr. Chairman, for holding not only today's hearing, but the series that you've planned as we work to bring health care to every American. One of the biggest problems in health coverage is including those who are left out of group coverage and must purchase insurance in the private market. These very same people not only face tougher access and higher cost issues, but they're also taxed on these plans. Any individual who receives coverage through their employer gets their plan tax-free. I think it's very important that everyone has the option to buy into a group plan that would mitigate costs and not discriminate based on pre-existing conditions. We don't want to upset the health insurance for people who have it and who like it. We want to expand affordable, comprehensive health care options to those who don't or those who want better coverage. So I look forward to a very distinguished panel's testimony today, and I hope we're able to discuss the tax treatment of health insurance and how we might address that as well. Thank you.
The ranking member of the full committee, Mr. Barton.
Thank you, Mr. Chairman. I've got an excellent statement that my staff's prepared. I'm going to submit for the record. But in the interest of time, I'm going to just submit it. The main thing that's in the statement that I think we need to put before yourself and the members of the committee is that the Republicans do want to work in a bipartisan fashion this year. We are willing to work with you and the full committee chairman and other members on the majority side to enact comprehensive health care reform if it really is reform. So this is not an issue where we're going to try to rope-a-dope the committee. We're prepared to work if it's something that is in the middle and can be done and maintain the private health care plans of America.
Thank you, Mr. Barton. I appreciate what you said, and I think it's crucial that we work in a bipartisan fashion, and that is certainly our intention. Thank you. The gentleman from Texas, Mr. Green.
Thank you, Mr. Chairman. I want to thank you for holding this second hearing on health care reform. Our state of Texas has the unfortunate distinction of having the largest number of uninsured in the United States. Nearly 5.4 million Texans, or 25% of the population in Texas, without health insurance coverage, and nearly 1.4 million children are uninsured. Of that 1.4 million, 900,000 children in Texas are S-CHIP eligible. We need a national system designed so that every American should be covered, either an employer-based plan, an individual plan, or a public plan, no matter what state they live. The largest rate of growth in the uninsured and underinsured are middle-class families who make too much to qualify for public plans, but don't make enough money to pay costly premiums under the private plans, and those who work in low-wage jobs without employer-based insurance. Ultimately, the large number of uninsured Americans create a vicious cycle by driving up health care costs, which increases the number of people who can't afford insurance. Mr. Chairman, I ask unanimous consent to have the remainder of my statement be placed in the record.
Without objection, so ordered, and thank you. The gentleman from Kentucky, Mr. Whitfield.
Thank you, Chairman Pallone, and I'm going to waive an opening statement.
Next is the gentlewoman from Colorado, our full committee vice chair, Ms. DeGette. Mr. Shimkus?
Thank you, Mr. Chairman. I, too, am excited about getting into this debate. Basically, how do we make sure we get insurance for those who don't have no insurance? So my focus has always been affordable, portable, and access. I do believe that the market-based system, which encourages price transparency and shopping around, is the best method. I do fear a government backstop plan action in which the government controls. And I'm deadly in opposition to a one-payer system, which I hope we don't segue into when this fight really gets going. I do not want bureaucrats picking health care decisions in the end. So having said that, it's great to be back on this committee. As I said, Mr. Chairman, I look forward to working with you. I yield back.
Thank you. Our subcommittee vice chair, Ms. Capps.
Thank you, Chairman Pallone. Since today's hearing is about ensuring affordable coverage, I want to quickly set the stage with a story about my constituent, Terry Turpin. Her story was featured in the Ventura County Star yesterday, and I'd like unanimous consent to enter the article for the record. She, like so many others, recently lost her job when her employer filed for bankruptcy. Unfortunately, Terry had just been diagnosed with a relapse of cancer only a month earlier. COBRA would have cost her well over $500 a month. So she applied for coverage in the individual market, but never heard back because of her pre-existing condition. Luckily, Ventura County has a wonderful public health system where she was able to get access to oncology treatment. Not everybody lives in a community that provides that backup. At the bottom line is that patients shouldn't have to switch providers in the middle of treatment because they lose their job. So I look forward to discussing today how we can improve access to affordable coverage for everyone. I yield back.
Gentleman from Missouri, Mr. Blunt.
Thank you, Mr. Chairman. I have a statement for the record. I do look forward to working with you and with Mr. Deal and the subcommittee to find a solution to this question of affordability. I think we can find common sense solutions. In fact, the Medicare Part D program that's been in place now for several years is an example of a program where for the first time the government organized a private, competitive-driven system rather than try to operate a system. The cost is lower, satisfaction is higher, seniors have more options. In fact, competition works, and it puts patients and healthcare providers in control. There is no government-run plan offered under Medicare Part D, and in fact, there's no government-run plan offered for members of Congress or any other federal employee, and I think there's a good reason for that. People want choices, and choices bring greater satisfaction. I look forward to the testimony today, Mr. Chairman.
Thank you. Chairman Emeritus, Mr. Dingell.
Thank you for your courtesy, and I commend you for this hearing. First of all, this is an important hearing on affordable coverage. Addressing affordability is a crucial piece of health care reform debate. This hearing will help guide us in our future deliberations. The amount that workers pay for health insurance has greatly outpaced the rate of inflation and certainly has risen faster than stagnant wages and incomes. The statistics are frightening. The share of family income spent on health insurance increased from 7.3% in 1987 to 16.8% in 2006. In 2006, 1/5 of the nation spent more than 10% of their income on out-of-pocket medical expenses. In 2007, 69% of the people who went without medical care or delayed needed medical care cited worries about cost, a 3.8 percentage increase from 2003. The average cost of employer-based family insurance policy in 2008 was $12,680, an amount almost equal to the annual earnings of a full-time minimum wage job. It is not just the uninsured population that suffers from the high cost of health care. More than 42 million people with health insurance report having problems paying medical bills. Of those who faced medical bankruptcies, almost 3/4 had health insurance at the time of the illness that left them financially unstable. Without any action, the expected cost of full family employer health insurance will increase to more than $24,000 in 2016, and the average deductible will reach nearly $2,700. This means that in only 7 years, almost half of American households will spend more than 1/3 of their income on health insurance. It comes no surprise to anyone that families are literally going bankrupt. The high cost of health care causes a bankruptcy every 30 seconds. At the end of the year, it'll cost 1.5 million the homes which they cherish. Furthermore, as health care costs dominate budgets, families will have less to spend on food, education, and necessities. As we continue the debate, we must ensure that every American has coverage, but we can't stop there. Increasing costs alone will get us nowhere if we don't find ways to reduce the cost of health insurance and health care delivery as a whole. Access to health insurance does not mean that individuals can utilize available services. They're also kept out of the circle of care due to high premiums, deductibles, and other out-of-pocket costs. I look forward to working with my colleagues and working with the leadership here and the administration. There are a number of worthy options being debated. I think public option is something that should be seriously considered as we move forward on health reform. While we've not decided the specifics of what a public option should look like, I believe that such option must be affordable, and it must have suitable benefits, and it must provide healthy competition in the marketplace. The insurance market has a nasty habit of gaming the system. of building barriers to affordable coverage, of excluding coverage altogether, or coverage for pre-existing conditions, and charging higher premiums for certain individuals, cherry-picking, and other games that make insurance unavailable to our people. I am confident if we weigh our options with an eye towards the end goal of providing quality coverage for Americans, we can pass a reform that benefits all of our Americans. We must do so because the consequences of not doing so are terrifying. Thank you, Mr. Chairman.
Thank you, Chairman Dingell. Next is the gentleman from Pennsylvania, Mr. Pitts.
Thank you, Mr. Chairman, for convening this hearing. Recently, the Pennsylvania Insurance Department released a survey of Pennsylvania health insurance. Let me just share a couple of results. Overall, in 2008, 15.3% of Pennsylvanians did not get some type of needed medical care during the past 12 months due to its cost. This represents about 1.9 million residents. Currently, 8.2% of Pennsylvania residents are uninsured. That's about a little over 1 million residents. According to the survey, the cost of health insurance remains the primary barrier to coverage. I believe any health reform plan must contain several key principles to empower the consumer. Among them, end tax policies that discriminate against an individual who purchases private health insurance on their own rather than through their employers, make it easier to decouple health insurance from employers. Those who own their coverage should be able to take their plan with them when they change jobs or quit working, and one they can take to another state. They should be able to buy from another state. Also, risk pooling within a state or across state lines. People should be able to choose the plan and doctors and services they want. And insurance and providers are accountable to them, not their employer or government bureaucrats. The bottom line is privately owned health insurance will lead to competition among plans, lower cost, higher quality, more choices, and more transparency. I thank all the witnesses for testifying. I look forward to hearing their thoughts and yield back my time.
Thank you. The gentlewoman from Chicago, Ms. Schakowsky.
Thank you, Mr. Chairman. I'll put my entire statement in the record, but I wanted to make a couple points. One, this debate about cost should not be about providing access to health insurance. It must be about providing access to health care. Too many insured Americans find that having an insurance policy is no guarantee that they or a loved one will be able to afford care when they need it. And finally, I want to point to a new report by the Illinois Main Street Alliance, in which 56% of small business owners in the state support a choice between a public insurance option and a private option. Those are the small businesses in our state. And finally, Mr. Chairman, I'd like to submit for the record a report from the Institute for America's Future, Massachusetts Health Reform, Near Universal Coverage, but no cost controls or guarantee of quality, affordable health care for all, if I may submit it for the record.
Without objection, so ordered.
Thank you, Mr. Chairman.
Next is gentleman from Texas, Mr. Burgess.
Thank you, Mr. Chairman. I was astonished a couple of weeks ago to be invited to the White House to the forum. I still haven't figured that out. But I was grateful to be there, and I heard the President observe that he just wants to figure out what works. And I'm certainly prepared to help him. Now, I always get a little bit discouraged on these panels and discussions. We end up talking a lot about cost and coverage. After all, as a physician, I can tell you it is about taking care of people in the final analysis. One of the things the President also told us was that the status quo is not an option. I would also observe that very little is static in the field of medicine, and in fact, in the 15 years since the last major attempt at reform was undertaken, medicine has changed drastically. Now, the President wants to figure out what works. We're going to hear a lot about former Governor Romney's proposal in Massachusetts that has now had a couple of years to go through a couple of iterations. It's a bold experiment. It deals with a connector. It deals with mandates. But maybe we should also look at Walmart, which in the past 4 years now covers, without mandates, 95% of its employees with affordable coverage. If we want to learn from what works, maybe we ought to include that in our broad-based discussion. You know, you look at the cost for the cost increases. It was referenced by former Chairman Dingell, the cost for indemnity insurance, PPO. In fact, Medicare and Medicaid all are going up in excess of 7% a year. Look at consumer-directed health plans, though, and they're rising at a rate of a little over 2% a year. It seems to me it would make sense that if we are going to deal with issues of cost and coverage, we would give a close look to those things that are working, particularly how Walmart has provided affordable coverage to its employees and how consumer-directed health plans have held the line on cost increases. I'll yield back the balance of my time.
Thank you. Gentlewoman from California, Ms. Harmon.
Thank you, Mr. Chairman. Healthcare reform can't wait. It is an integral part of any economic recovery strategy, and I think it is very good news that both the Obama administration, this Congress, and this committee know that. Let me just make 3 brief points. First, I'm new to this subcommittee, but not new to this issue, and I welcome the opportunity to be a player at some level as we craft legislation. Second, I urge that all of the expertise on this committee, starting with our chairman emeritus, but including every other member of the committee, Democrat and Republican, be tapped as we draft a bill. Third, of special interest to me is the lack of surge capacity in our healthcare system. Should we have another major terrorist attack or near simultaneous attacks, I would bet that all of our trauma centers will be full to capacity even before the latest victims get there. And finally, let me say that both wellness and preventive care are the cheapest options for health care, and I hope we feature both as we craft a bill. Thank you very much.
Thank you. The gentlewoman from Tennessee, Ms. Blackburn.
Thank you, Mr. Chairman. Thank you for the hearing, and welcome to our guests today. You know, there's a saying, nothing in life is free, and in Tennessee, we have figured this out with our TennCare system. It's become proof of that. We've learned that comprehensive health care packages for all cannot be affordable. Government's resources to provide care are fixed, and as we learned, intervention can exacerbate rather than control the growing cost of health care, and Tennessee has been TennCare has been very problematic for our state. TennCare kept a blind eye to rising costs and overgenerosity. It imposed no limits on days in the hospital or number of prescriptions that were allowed each month, and in the mid-90s, each TennCare enrollee received an average of 30 prescripts per year. However, health outcomes in the state did not improve. So to control cost and expand care, we must look to market forces, not look past them. And while the private sector is in need of reform, it is more effective than the proposed government-run options being floated to bring about more efficient, higher quality, and more effective health care. This hearing is entitled Ensuring Affordable Coverage. I believe it should be entitled Ensuring Access to affordable health care options, and I say that because of the experience we have had in our state. The nation will achieve high-quality care at a lower cost when Americans are empowered to make choices and become prudent health care consumers. Thank you, Mr. Chairman, and I yield back my time.
Thank you. The gentleman from Texas, Mr. Gonzalez. Mr. Gingrey.
Mr. Chairman, thank you. Ensuring affordable quality health care for all Americans is a worthy goal, indeed a necessary goal. We should work to ensure that low-income families, those with disabilities or chronic diseases, and all who purchase health care on their own have the same opportunity to access health care as their neighbors. But access to an insurance card, no matter if that card is for a family health plan or a government program, it does not guarantee access to quality health care. In my state of Georgia, the number of general physicians has declined over 15% in the past 10 years. Unfortunately, Georgia is not an isolated case. Mr. Chairman, access to quality health care should mean that all Americans are able to see a qualified medical professional and receive a life-saving treatment or drug when they need it. Going forward, Mr. Chairman, it's my hope that this subcommittee will not lose sight of the fact that we will destroy, not improve, but destroy health care if we take actions to reform the system that drive doctors out of the practice. Thank you, Mr. Chairman. I yield back.
Thank you. The gentlewoman from the Virgin Islands, Ms. Christensen.
Thank you, Mr. Chairman. I waived my opening statement.
Gentlewoman from Florida, Ms. Castor.
Thank you, Chairman Pallone. Our neighbors and folks all across this country are depending on us to tackle this health care reform effort and help make health care more affordable for their families. So we need your expert testimony now more than ever. The stakes are very high in my home state of Florida that has the second highest rate of uninsured. In fact, I was going through the comment cards in my office last night, and health care is the #1 issue. They know that it's not just their well-being, it's their economic well-being in a very difficult time. One constituent shared a story. I guess they felt so compelled, they were so offended by the fact they were waiting in line at the pharmacy behind a woman who was picking up insulin for a relative. And the pharmacist had to say, I'm sorry, your private HMO has declined coverage. We cannot provide the insulin. And they said, there's no other option? No, there's no other option for this expensive insulin. We cannot provide it to you. So that person, that neighbor waiting behind, felt so compelled to write to their member of Congress to say, this just is not acceptable in our country. The proof of dysfunction is legion. Now what we need are the solutions. So I look forward to your testimony very much, and I know that this committee will act expeditiously this year on health care reform. Thank you.
Thank you. The gentlewoman from Ohio, Ms. Sutton.
Thank you, Mr. Chairman, for holding this important hearing. I'm particularly interested in today's topic of making health care affordable for working families. Unfortunately, our current system is far from affordable, and every day we wait, there are consequences. Ask Tammy Witt from Ohio. She was diagnosed with stage 3 breast cancer in April of 2006 and had to undergo a mastectomy and 9 months of radiation. Tammy was receiving what she thought was comprehensive health insurance from her job, but Tammy's low annual insurance benefit caps left her with unaffordable medical debt that eventually caused her to declare bankruptcy. Like Tammy, far too many Americans have to worry about facing bankruptcy when they become ill because of the cost of health care. We can do better, Mr. Chairman, by Tammy and families across this country. We have to do what we can to rein in costs and make health care more accessible and affordable, and I look forward to hearing from our panelists today.
Gentleman from Iowa, Mr. Braley. Ms. Baldwin.
Thank you, Mr. Chairman. I hear from my constituents every single day about the high cost of health care, whether they are insured or not. Brenda, a constituent of mine, was self-employed as a children's book author. Her small income disqualified her from being eligible for Wisconsin's public health insurance program, and she couldn't afford to purchase health care in the individual market. Last year, Brenda got a small kidney stone, but because she was uninsured and could not afford health care, she delayed getting it treated, to the point where she had to be hospitalized with severe infections and internal bleeding. She's no longer able to work and receives insurance from the public health insurance program now. We absolutely must tackle this issue if our reform is to succeed at all, and we must ensure that individuals like Brenda are able to access the care they need when they need it. In my last couple of seconds, Mr. Chairman, I just wanted to respond to some of the comments we've heard about having public sector options along with private sector options. Medicare Part D is used as an example frequently. I would note that in the state of Wisconsin, I think we're the only state that has a public sector option in the Medicare Part D program. It is very, very successful, and I hope that we'll be able to study it further as we have this debate about whether there should be both public and private sector options available to our constituents.
Thank you. Gentleman from Connecticut, Mr. Murphy.
Thank you, Mr. Chairman. I hope that we spend some time this morning talking about the fact that just because you have health care insurance doesn't necessarily mean you have health care. This is an important distinction that needs to be at the center of this debate. For instance, in Connecticut, we have a very generous Medicaid program, but because it doesn't pay doctors enough to be part of it, we have Medicaid recipients that can't find a psychiatrist or can't find an orthopedic surgeon no matter where they go. Before I came here, we had to pass a law in Connecticut that cracked down on private insurers that were charging $200 copays for MRIs, basically putting the entire burden of that procedure on the consumer. Universal health care insurance and universal health care are potentially very different things, and I hope that this hearing will push Congress towards passing a health care reform bill that guarantees that every American gets quality health care that they can afford, not just a claim of coverage or phantom access. I thank the panel for being here, and I look forward to hearing from you today.
Thank you. Gentleman from Utah, Mr. Matheson.
Thank you, Mr. Chairman. Cost is the issue. And today we're talking about affordability for families. We should be talking about affordabilities for everyone in America, families, businesses, the effect on small business. There's a lot of talk about access and making sure everyone has access to health care. If we give access to everyone under our current system and don't take steps to create reform in our system to make it more efficient, we're going to drive off the financial cliff even more quickly than we're headed right now. So I encourage this committee to continue to look at ways to make this system better. The good news is there's tremendous opportunity to make it better without spending more money. The current system is inefficient, it's not productive, it's got perverse incentives built throughout its structure. It's got a bloated administrative component that I can't believe we put up with as a country. So I think there are great opportunities for this committee to act in the best traditions of the Energy and Commerce Committee in a bipartisan way, to be substantive, to look at multiple variables that really need to be addressed if we want to reform our health care system. That's what this committee ought to do, and I look forward to this hearing and additional hearings in the future. Thanks, Mr. Chairman.